are better able to manage this virus, and in particular as they go to work and go to school, and as we prepare for going back to school in the fall. The second topic has to do with regular full submissions to our office. So we are now in the process of removing all Medusa files that for full authorization that were on hold. The vast majority have already been taken off hold, and going forward, we're not going to place files on hold due to workload issues. There is one area, though, where we still do not have the bandwidth to handle currently for regular submissions. And this has to do in the category of what's called pre-submissions or Q-subs. And we are reviewing a select categories of pre-subs. These are not pre-EUAs, these are normal full submissions, sort of pre-submissions. And they include COVID related pre-submissions. So for those developers who want to see feedback on their proposed plans for converting to full authorization, we are accepting pre-subs and we are reviewing pre-subs. We would ask, as with all other full authorization sort of submissions, typically we're doing our best to hit our Medusa guidelines for times, but we are swamped, and we're going to do our best to try to hit the usual timelines, but in some cases, if not many, we're going to have to give a bit longer due to the workload and continuing workload for COVID. So the other pre-subs we will be continuing to review are breakthrough requests, IDE requests, and companion diagnostic requests. So the whole point of bringing up Medusa is to, generally let people know about what we're doing on that front, but also to encourage those test developers who want to have a COVID-related test on the market for long term, that we're open for business on pre-subs for COVID and on full submissions for COVID. Of course, for the lion's share of molecular tests, we've already authorized one de novo, and that means all subsequent molecular submissions for SARS-CoV-2, whether they be a single analyte for SARS-CoV-2 or a multi-analyte panel. They all, they meet the other criteria to fall under that the new pathway. I can submit a 510K. For serology and for antigen tests, the first submissions will be de novo. Thereafter, the lion's share of those will then also be the 510K. So we do actually urge folks, developers who want to be on the market long term with the SARS-CoV-2 test to begin turning their attention to this and preparing for full authorization. And in particular, making sure that they have the samples needed where banking of samples is allowed to do all the analytical work as well as the clinical validation that we expect for those full authorizations. So now's the time, I think, to not delay turning attention to that. We hope that there's about 40,000 new infections a day in the U.S. right now, which is still substantial. We do hope that continues to fall, and it falls greatly. So we have seen following prior emergencies where developers, when they turned attention to moving towards a full authorization, the positive samples fell off, and they struggled at times at for getting positive samples. So I just bring that up because I think the FDA is obviously interested in full authorization, and I think developers are too. And I wanted to bring this up, and I will be probably reminding developers of this relatively frequently going forward. Okay, those were the two topics I wanted to cover. Now over to Toby. Thank you.
Thanks, Tim, and thanks as always to everyone for joining us again this week. We do have a few questions that came in that we're going to address before we open it up to the phone lines. So the first question that we have is asking about saliva collection devices and whether a saliva collection device or a specimen is added to BTM prior to testing needs to have an EUA. And the answer is yes. There currently are no FDA cleared or approved saliva collection devices intended for use with viral RNA. Since these are not 510K exempt devices, FDA authorization, either through full pre-market review or through EUA, is required for these saliva collection devices. We have to date issued 3 EUAs, I believe, for saliva collection devices for use with SARS-CoV-2 tests. And we recommend that you look at the authorization documents for those 3 EUAs as a reference point. Additionally, the home specimen collection molecular diagnostic template includes some recommendations, including for analytical and clinical studies that may be applicable, even if the saliva collection device is not intended to be used for home specimen collection specifically. The next question that we have is regarding bringing a lateral flow rapid antigen test to the market for asymptomatic self-collection with serial testing using anterior nasal samples. The question is regarding the clinical protocol, and the developer's preference would be to do their clinical study in the home setting with nailed kits rather than in a simulated home environment. And they're asking about using an FDA authorized comparator test, but noting that there's a concern with this question is asking about using an antigen test for the comparator, which we'll get into, that is not recommended. And there's a concern about collection from both anterior nares, and concern that if the comparator sample is drawn first, it would reduce the sensitivity of the subject device. So the question is asking whether FDA would allow use of a saliva-based comparator, even though the test in question is using a nasal sample. So we'll address a couple of the different points of that question. The first, performing the study in a home setting instead of a simulated home environment is potentially acceptable. However, we do recommend a high sensitivity PCR using a nasal specimen as a comparator. Neither saliva specimens nor antigen tests are acceptable comparators. You should select a high sensitivity PCR that is authorized for home collection, and use the home collection kit with which that selected comparator test is authorized. In order to address the concern of which sample is taken first, we recommend that the collection of swabs should be randomized so that the antigen and PCR tests are not consistently drawn in the same order, and that both interior nares should be sampled for each test. We would also recommend that you send in a pre-EUA with your study design and check the comparator selection with FDA prior to initiating your study.
Thanks, Toby. I'll just add a little bit on the concern about losing sensitivity for the test device. We have seen developers do this and do it successfully. We would recommend that there is a gap between the first collection and the second collection of probably a minimum of 10 to 15 minutes. And when we've worked with developers before and we've done this, we haven't seen a drop-off in sensitivity for either the comparator or the test device. Thanks, Toby.
Thanks for that addition, Tim. The next question we have is asking about the availability of the NCI laboratories to validate antigen test kits. So we want to clarify that NCI testing is not currently available for antigen tests, and all validation studies should be performed by the test developer to validate the proposed intended use population. The NCI test evaluation program is actually for serology tests. And if you have specific questions about that program, please send them to your lead reviewer if you have one, or to the EUA mailbox if you don't yet have a lead reviewer, and we're happy to answer those questions.
Yeah, and I'll just add that, I mean, it's a great idea to have banks for antigen tests. The challenge is that direct swabs are usually the sample type here for antigen tests, and banking those in significant volume where there's consistency between swabs in a bank is quite challenging. For those tests that use VTM, it's a little bit easier to use bank samples, but since most antigen tests don't use VTM in their usual workflow, that presents the challenge for having panels for antigen. So we are working with RADx and other programs to see what we can do. The primary focus right now with these sort of banks is finding better ways to assess the potential impacts of mutations and variants on antigen test performance. Thanks. Back to you, Toby.
Thanks, Tim. Our next question is about analytical performance testing for an antigen test. First asking whether recombinant or purified antigens spiked in negative clinical media can be used. So antigen in negative nasal media, for example. And the answer there is no. That we don't consider the use of recombinant or purified antigen to be acceptable for any validation activities, since it doesn't test the extraction step of your test. And we found that performance with recombinant or purified antigen does not correlate well with real-world performance. The second
add.
Go ahead.
Oh, go ahead, Toby. No, Toby, go ahead. I'll
Okay.
I'll say something again.
Sure. The second part of that question is asking whether laboratory-based analytical performance testing, such as stability, limit of detection, can be performed outside of the U.S. And that answer is yes. Lab-based analytical testing can be performed outside the U.S., but we do expect to see the full detailed protocols for each validation study as part of the EUA submission.
Yeah, I'll just add something on question one. So, absolutely correct what Toby said about authorization decision. However, it may be easier for some developers who want to monitor performance with respect to certain mutations and variants to use engineered antigens, recombinant antigens in particular, because they can engineer in the mutations. Not sure if that's going to be sufficient only in assessing change in potential performance with mutations, but certainly it's a good thought, and we're open to that, just for verifying performance on mutations. So that's one area where recombinant antigen production may be entirely useful in addressing concerns. And we look forward to having conversations with developers on this to make sure that's addressing any potential concerns the FDA may have. Thanks, Toby. Back over to you.
Thanks, Tim. That's really helpful. The last question that we have pre-prepared here is about antibody tests and about monitoring the performance of a lateral flow antibody test in relation to variants. They're asking how many of each variant sample are required to be evaluated, and whether there's a specific method required for confirmation of positive. So for the first, at this time, we don't have specific recommendations for the number of SARS-CoV-2 variant-related serology samples that should be evaluated by wet testing to monitor the performance of SARS-CoV-2 serology tests. In your EUA request, we would like to see your plan for monitoring for new and emerging SARS-CoV-2 viral mutations and variants, and we would expect your plan to include assessing the potential impact of mutations and variants that have been identified as prevalent or clinically significant on the performance of your test. Wet testing is not expected for every variant that you monitor, but for mutations and variants that have been identified as prevalent or clinically significant, you should provide information on the potential impact on your test performance, considering your specific capture antigen and test technology, or explain how the risk associated with the unknown performance of your device in samples from individuals with the variant can be adequately mitigated. And then when variant data is provided, we would expect you to describe how the serology samples were selected and characterized, and describe the sequencing methods used to call specific variants. That should be included, this should include describing the sequencing method validation, such as inclusivity and limit of detection, and describing the sequence analysis steps used to call mutations. And
all right,
that is it from me.
Yeah, I think we can open it up for live questions. Thanks, Toby.
Yep.
Thank you. At this time, if you would like to ask a question, please press *1 on your touch-tone phone. Please ensure that your line is unmuted, and please record your name when prompted so that I may introduce you. Our first question is from Franco Calderon. Your line is open, sir.
Thank you for taking my call again. My first question is regarding a paper that I read from last week regarding mutations 1051 and D399N. This was a study done by the University of Washington, and regarding how these mutations affect the N protein, and they took two tests, the Sophia 2 Quidel and I believe the Abbott Binax now, and they measured their performance regarding these mutations, and they found some interesting results, I believe, affecting the Sophia 2. The question is FDA going to be updating the template, the antigen test template, because of this development, even though the prevalence of these mutations at this time appears to be very low? The second one is regarding our ability to use labs outside the U.S. to do the analytical work, which I really appreciate. The question from my lab is whether FDA expects that the lab be GLP or ISO 17025 would be okay. And let's see, and regarding the number of matrices that we need to test for a nasal swab antigen test for at-home use, how many are we expected to do? How many matrices? Because it's not clear to us on Part J, Part 1 of the template.
Yeah, those are a lot of questions. I'm not sure that I know I didn't capture all of them. I captured the D399N mutation in the first question. What was the other mutation?
The other mutation is the first one is the T2051. The second one is the one that you mentioned.
I'm not familiar with the T2051, so off the top of my head, I'll get to it. But the 399N, it is in very low prevalence in the United States right now, well below 1%. And so, and we know that we know about the report that Sophia, SARS, and any of because it's in so low abundance, it does not reach, if in fact it is confirmed that the Sophia test doesn't detect the 399N, we won't be updating the website because we're reserving updating the website where we think that the prevalence of certain mutations that could impact performance is high enough that it warrants a website update. So we're really looking at either individual mutations or a combination of mutations for antigen tests that would drop performance by 5% or more. Same goes for molecular tests. And so we do have guidance on what developers should do regarding variants, and we are very active in monitoring the variants, obviously, and talking to developers. And when it becomes important to make that information publicly available, we now have a website and post the information there. Toby, do you have anything else to add on variants and mutations?
No, I think you've covered it all.
The second question, I think it had to do with analytical studies and the type of lab that you do the analytical studies in. We do waive for EUAs much of QSR regulation, and that's spelled out in the letter of authorization. So while we always love it when developers, even for EUAs, do it fully within QSR compliant facilities and methods and everything, we are more flexible. So I don't believe we have a specific laboratory requirement. We do recommend that you properly design your analytical studies and you form your study plans and document it before starting the studies. And because we will want to see those study designs for the studies and for their appropriateness, and then so that we can measure the effectiveness. Toby, do you have anything to add, correct, on my?
No, that's correct. But we focus on the protocol and the data, so we do want to see those in detail.
And the third question, I think, had to do with different sample matrices that we recommend for a test and test developers. We really only need one that works, right? So if analytical, if interior nares sampling, bilateral anterior nares samples gives you adequate performance to meet our recommended level, that's sufficient. And then it's really a developer whether they want to do more. And it can be an MP swab, it can be a mid-turbinate swab, for antigen tests. But it's really what the developer wants, as long as it's an acceptable sample type and properly validated and able to be authorized. I hope I captured the third question because I wasn't sure that I was.
You did. Thank you.
All right, thank you. We'll move on to the next caller.
It's from our next question is from Ella. Ella, your line is open.
Hi, thank you. My question is about antigen saliva test and the cross-reactivity and interference studies. So for saliva test, I'm wondering what would be okay to use as the clinical matrix. Can this be artificial saliva, or does it have to be fresh saliva, or could it also be from a commercial source? I understand that some saliva bought commercially, because it's been stored for a while, it can degrade.
I recommend submitting a pre-EUA for your saliva antigen test and your plans. Typically, we won't allow, completely artificial samples for anything right now, including saliva. And the use of bank samples, especially for analytical studies, fine. The use of contrived samples is generally okay for analytical studies, meaning you take a negative patient saliva or pooled saliva, and you spike in virus, whole virus inactivated, will work. Or you can dilute a positive patient saliva sample into a negative pool in order to get the dilution that you would want for your analytical studies. But again, we don't have recommendations out there on validation of saliva antigen tests. We do think that's a particularly challenging sample type for antigen tests. There's a growing body of information that it is significantly less, sometimes for saliva, amount of virus. But, we're open to it. We're not saying don't do it. It's just, I don't believe we've authorized one yet. And we haven't yet, obviously, then received an application for a saliva-based antigen test, but we could have.
Okay, thank you. Sorry, can I ask a follow-on question then?
Sure.
For the clinical evaluation, is it okay to use bank samples if you're having difficulties collecting enough positive samples? I understand for molecular tests that's acceptable if one has tried to collect for 2 weeks. Is that the case for antigen tests as well?
Antigen tests are more challenging because we have observed that the freeze-thaw process seems to increase access, so we say, to the antigen. And it's an artificial increase in assay sensitivity that is hard to control and understand. And we really want to understand real-world performance. Anything that doesn't follow our sort of standard recommendations for antigen tests. Again, I do recommend that you submit a pre-EUA and ask for any, flexibility that you need to develop your test. But molecular is a little bit different because they typically have an extraction step. And for those assays that, although we do examine whether freeze-thaw does impact molecular as well, so we do ask for freeze-thaw. But with antigen, it's been pretty consistent that the sensitivity increases with freeze-thaw.
Thank you.
Mm-hmm.
Thank you. Our next question is from Don Catheter. Your line is open, sir.
Yes, hello. Thank you for taking the call. You mentioned in several of the meetings the desire to move towards full approval for COVID tests, and the only one that you've approved is the de novo from BioFire. And it would be most helpful, I would think, for developers to see the decision summary for that assay, which is still not available according to the database. So I'm wondering if you could shed any light on when and if that decision summary will be made available.
Yeah, Toby will know the exact protocol for these to get posted, but it goes through a process of looking for any proprietary information about the assay that we authorize that shouldn't be disclosed publicly. So it leaves our office and it goes through this process, and we're not entirely in control of it. We can't, just like guidance, we can't predict when it's going to come out. However, for those developers for molecular serology and antigen tests that want to pursue full authorization, as I said, we're accepting pre-subs for COVID-related applications. And as soon as we can post that decision, we will. Toby, do you, along with the special controls, Toby, do you have anything to add?
Yeah, we have been working to expedite posting of that. It has hit some, it does need to go through a procedure. And it is unfortunately not the fastest process in the world, but we are working to expedite it because we do know how valuable that would be for developers to have access to.
Yeah, I would reiterate that it would be valuable, and hopefully before 2 months is up, we should be maybe seeing it, I would hope. Thank you for your answer.
Again, it's not in our full control, otherwise it would be out. All right, thanks.
Thank you. Our next question is from Richard Theron. Your line is open, sir.
Hello. I have a question about biorepository and bank samples versus antibody test, can you restate CDRH's position as what's acceptable for biorepository test versus a live specimen?
You're talking about serology and molecular?
Precisely.
I think we, for central lab tests, moderate and high complexity labs, test authorization, frozen samples are largely acceptable for that. We'll want to see pre-stock studies to make sure that they behave the same, taking paired samples. When you move into point of care or home situations, that's where it gets a little bit more tricky. I don't know if our current templates spell out the use of banked samples, but we always do recommend that if you're going to use bank samples for your analytical and clinical studies, that you do check through the pre-EUA process, and if you're going for full authorization through the pre-sub process, to make sure that your design of studies using bank samples mitigates completely or to the extent it can be any sort of bias. Would there be anything else there?
No, nothing for me.
Okay, as a follow-up to that, what would you say would be the sensitivity limit requirement for a centralized laboratory test versus a home-use or point-of-care test?
I'm not sure I understand the question. Can you restate the question, please?
With regard to home-use tests, would the sensitivity minimum limits be different for a home-use or point-of-care test versus a centralized laboratory test?
Yeah, clinical sensitivity or a positive % agreement to a comparator or to the test of record. For molecular and serology, then they would be different answers for that. I think we have. Well, I know that the home template for antigen and molecular spells out. And then I think we have a home collection template for serology. So you should be able to get a good idea. Basically, for serology testing, we really sort of have a set level of sensitivity with PPA recommendations as well as specificity or NPS. And for home and for point of care molecular, it's 80% is the floor that we recommend. We really like to see good concordance to central lab molecular tests for all molecular tests, whether they be in the home or point of care. But we will authorize molecular tests between 80 and 95% PPA compared to a high sensitivity central molecular test. And the same thing for home molecular tests. And then there are various thresholds for different applications, such as if you want OTC. There's different pathways for the OTC. And those are all laid out fairly clearly in our template, so I'm not going to go over those again right now.
Thank you.
Thank you. Our next question is from Josh Profetto. Your line is open.
Hi, thanks for taking my call. My question is about your priorities. At the top of the call, Tim mentioned that you are prioritizing asymptomatic amendments for the reopening of schools in the fall. And I'm wondering whether that would extend to new submissions for asymptomatic testing. We've had one of these assays, molecular slab-based high complexity, that the review has been held up for about 6 months or so. And it was always our intent to submit an asymptomatic amendment once we got that authorization. But I'm wondering if we were to resubmit a new EUA now with the asymptomatic validation, whether that would be a higher priority. Thanks.
Yeah, with the central lab tests, we are also asking for, it be a high throughput test. So a low throughput test isn't really capability as a country to address the huge numbers of tests that are needed for asymptomatically screening our population. And we're really driving development priorities towards those extremely high throughput tests. And those are the ones that we're prioritizing. So simply a new submission, adding asymptomatic screening that doesn't also meet our access. Our access is point of care in home, but if it's a moderate to high complexity test and it doesn't meet the high throughput template, it's not gonna be prioritized right now, and it probably won't be going. The irregular full authorization pathway is open to test developers who don't meet our pandemic priorities, which are probably going to be pretty similar going forward. And so that pathway is open to them. We are accepting the applications, as I said at the beginning of the call, and we're not putting them on hold. They may take a little bit longer than we'd like.
Okay, thank you.
Mm-hmm.
Thank you. Our next question is from Maria Ramos. Your line is open.
Hi, thank you for taking my call. My question is in regards to the Quidel Sophia 2 instrument. You spoke about that less than 1% variant mutation that's not being detected. Is that why Medicare is declining payment for this instrument, or recategorizing it as moderately complex or high complexity?
I thought it was authorized for CLIA wave settings.
I can address this one.
Okay, good. You know what I use it. Go ahead.
Yeah. This has come up. I'm not going to be able to give you full information because it really is out of CMS, and so we'll recommend that you reach out to CMS. If you email the CLIA program, they'll be able to address your question. There is what I understand from talking to our CMS colleagues is that there's a misunderstanding, and there's not. They haven't recategorized anything. The Quidel Sophia is authorized under their EUA for point of care, which is CLIA certificate of waiver setting. And if you reach out to CMS, they'll be able to clarify the payment side of things for you.
Okay. Well, thank you very much. They published a recent coding guidance on their,
there's something about the codes that I don't fully understand, and there's some add-on to it that there's confusion over, but they're aware of the issue and are able to answer your questions much more eloquently than I would be able to attempt to do.
And if you haven't already, it's good to chat with the specific developer of a test that you're having any sort of reimbursement issues with, as they potentially can help as well.
I have. I definitely have. I've looked everywhere and I found no foundation for this. So my next question is what was a bit confusing is what role does the FDA play versus CLIA in recategorizing testing devices? Can CLIA just come in and recategorize?
So again, they have not recategorized. They're what they put out is specific to payment and is a coding issue. The FDA is responsible for, outside of an emergency, we do CLIA categorization. Under the EUA, we don't do a formal categorization, but we authorize for specific settings, which is sort of parallels that CLIA categorization that we would do on a full marketing submission. But that does fall under FDA, the determining what settings a test can be used in under that authorization. The CLIA and CMS side is, authorized on the CLIA side, authorizing or certifying the labs for a specific level of testing, and on the reimbursement and payment side of things, determining what gets paid for. And I think that really is a misunderstanding based on possibly the way that they worded their document. I'm not sure, and they'll be able to resolve that.
Okay.
So just for clarity, under federal law, it's our office that is the office that under normal circumstances categorizes tests as high, moderate, or waived. Under EUA, we are not making formal categorizations, but it still falls to our office to do this. And so we're calling it deeming tests for categorization. This mostly applies to those tests that we're deeming as waived. And we're not currently, until those tests come for full authorization, we're not doing a formal categorization. And as Toby mentioned, this test was, it sounds like, appropriately deemed waived by the FDA, by our office, and so this is some sort of paperwork problem, and hopefully quickly resolved.
Perfect. Thank you so much for your time.
Thank you. Our next question is from Lisa Olmert. Your line is open.
All right, thank you so much. I have a point of care question. Do clinical research organization sites qualify as a point of care setting? And the reason why I ask is that, clinical research organization sites often screen subjects before seeing them versus a typical clinic of all comers, where they will test, as appropriate for a clinical study, let's say, while providing patient care. Does that make sense?
I think so. I mean, it depends. We're really looking in the point of care study. The typical setting is a typical busy, primary care sort of facility, and we're looking for the ability of folks and healthcare workers who are not trained laboratorians in the midst of their busy daily schedules to be able to use the test and get accurate results. Because in the real world, that's what's happening. And if you've ever been to a busy point of care clinic, these folks, they're juggling a lot of balls. And want to make sure that the device is robust enough, the instructions are robust enough, that they still get accurate results. So that's the ideal. If you're contemplating settings other than what I've just described, I would recommend submitting a pre-EUA and describing it and getting and having a discussion with our staff on whether that's appropriate or not. We don't want you to go ahead and do a study and then it be lacking in some way.
Right. Thank you so much.
Uh-huh.
Our next question is from Jackie Chan. Your line is open.
Well, this is following up on the previous question on priority. In particular, if a developer has multiple tests that meet unmet needs, such as the neutralizing antibody test or other type of technologies, say it is not on a high throughput platform, that so it is not, so it cannot test at least 150 tests at once, but it can still test multiple tests at once. Is this of a lower priority than other POCC sites or the bigger platform tests?
Yeah. So again, we're looking at access, and so it's home, it's point of care, or it's high throughput. It really needs to pass those bars right now. First, those thresholds. Having a great neutralizing antibody assay that can't really help that many people is not going to address the country's needs right now. So we are, this is, these priorities are out there for clear reasons. One is to inform developers of what we're not prioritizing. And it also is to hopefully stimulate developers to develop the tests that are really needed at this stage of the pandemic.
Okay, can you define high throughput? Is it at least 150?
Yeah, as we said before, if you want to check and see if your test will meet current priorities, do send in a pre-UA with relevant information for us to assess that. You don't have to fill out a full pre-UA if you're going to use the templates in the template recommendations as intended. You can simply say, our one question is, do we meet the high throughput goal? That is something that that we're not publishing right now because as we go through the pandemic, that may elevate and if the needs change. So it's best just to check with our staff through the pre-UA process to see if your test would currently match our priorities.
Thank you.
Thank you. Our next question is from Dana Hummel. Your line is open.
Thanks for taking my call. My question is regarding an antigen rapid test for home use. So for the usability study, the FDA recommends 50 patients self-test and 50 patients collect the specimen on another person. If we have someone enrolled who collects the sample from another person, such as a child, can that same patient then run the test on themselves as well and be counted in the 50 as the self-test group, or do we need 100 unique patients to perform the test?
I believe you can use that same adult to self-collect and to collect the child. And yeah, so I think that's acceptable to make that a more efficient study. We're looking at usability of self-collection as well as usability of an adult in a home situation collecting a child and making sure that the adults can do both things well and safe.
Okay. And then a quick follow-up for the same test for an anterior nasal swab antigen test for home use. For the clinical evaluation study, you mentioned at the beginning of the call that the comparator should not be a saliva PCR test, correct?
Correct.
Okay, so should it be only an anterior nasal swab PCR test, or could it also be a nasopharyngeal swab PCR test?
It can be a nasopharyngeal swab. It can be a mid-turbinate swab. It can be an anterior nasal swab. We recommend both nares on the anterior nasal swabs. What's most important is that it's a high sensitivity molecular test that has an extraction step. And we do recommend that developers check in with the FDA to make sure that the comparator is going to be an acceptable comparator ahead of time so that there's no having to redo anything. Okay? Just check with us. We want to make sure that you're using an appropriate test that will allow us to make an assessment on whether the test can be authorized.
Okay, so even if the saliva test is a high sensitivity PCR test, just because it's not the same sample type, that's why we shouldn't use that one?
Saliva continues to be a problematic sample, and we're seeing issues with it as a sample type, and so we're not recommending it as a sample type for a comparator test.
Okay, perfect. Thank you so much.
And just to add a little bit more on your question about the usability study, since the intent of the usability study is to assess how well the user can follow the instructions, while having the same person perform both on themselves and on another individual would be assessing different aspects of those instructions. It would, potentially impact the ability to evaluate, how well a larger group can use the instructions. So you're sort of reducing the size of your usability study effectively. So you may want to take that into consideration in case that may impact your analysis for the results, and you may want to send a note to the inbox to discuss some of the further nuances there.
Okay, that makes sense. Thank you.
Our last question at this time is from Michael Zhang. Your line is open, sir.
Hello. Thank you very much for taking my call. I have a question on FDA policy for receiving EUA submissions. I've heard that the FDA has plans to no longer receive EU submissions for antibody tests in the future. I just want to confirm if that is accurate, or whether there are any plans to phase out EUA submissions for certain types of tests in the near future.
That's incorrect on serology tests. But we are if a test is not high throughput, we are declining to review as part of a prioritization process. So if someone, say, has the lateral flow assay and they're only validating it for a high complexity lab, that's not currently meeting our priority. Serology tests that are point of care, home collection, we're still reviewing if they are complete applications, and if they are high throughput tests, central lab tests, as we've authorized a number of them, we are continuing to review those. So I'm not sure where you got your information, but it's not correct.
All right. Thank you very much.
At this time, I have no